Okay, good afternoon, everybody, and good morning to the resource persons who are from the Netherlands. But good afternoon to the Sri Lankan participants who are joining and anybody else depending on the time zone. First of all, I'm delighted to welcome all the participants and the resource persons from the Netherlands to the post-conference symposium on a very timely topic, better preparing healthcare trainers for future practice, the potential of interprofessional education. I must say it is very much aligned with the conference theme of empowering learners to transcend boundaries of healthcare delivery. We have a team of eminent speakers from the Netherlands and one from Indonesia, and they are exploring the topic that I mentioned above. And I would be introducing the speakers in a while, but just to introduce the symposium now, as you all know, world over, healthcare professionals are confronted with increasingly complex problems. And we know that non-communicable diseases are on the increase. An increasing aging population is seen, and pandemics of the nature of COVID-19 that we faced recently and which continues to be with us is there. So we understand what it is and the importance of teamwork here. So tackling these problems effectively and efficiently require collaborative action by multiple healthcare professionals. And ever the increasing expectations of the patients also require this kind of approach. And now during the symposium, there would be 4 presentations intended to explore the potential and pitfalls of interprofessional education from a theoretical and a practical point of view. So let me introduce the speakers, and I would start with Dr. Renee Stelmeijer, PhD, MSc, who is currently an assistant professor at the School of Health Professions Education, Maastricht University. She is trained as an educational scientist and has been active in the field of medical education since 2005. Her research focuses on workplace learning and the interprofessional learning and its teaching dynamics. She is head of task force program evaluation at the Faculty of Health, Medicine and Life Sciences at Maastricht University and teaches research methodology in the School of Health Professions Education. And on a personal note, Renee, you were my buddy during the, the final presentation of my PhD thesis in Netherlands. So I'm so happy to welcome you and introduce you. Next, Professor Dr. Yassa Dinuya has an academic background in health promotion and in health professions education. She focuses on education and research at the boundaries of both disciplines. She is also Director of Education for Health and a member of the Board of Directors at the Institute of Education, Faculty of Health, Medicine and Life Sciences. She joins the School of Health Professions Education, Maastricht University, the Netherlands. Then we also have Endang Estari, who has a PhD and MSc, is teacher at Faculty of Medicine, University Islam Sultan Agung in Samarang. She's from Indonesia. She graduated from Master Program of Medical Education at Universitas Indonesia in Jakarta in 2008. She finished her PhD from School of Health Professional Education, Maastricht University in 2021. Since 2005, she has had various roles with regard to educational development and quality assurance, amongst which implementation of PBL curriculum at the institution. Head of IPE team in the university, enabling IPE implementation and IPE faculty development program activities on IPE since 2017 up to the present. She has been the head of quality assurance unit of Faculty of Medicine, University Islam Sultan Agung. Okay, and so although it's last, let me welcome Professor Els Boshusen and introduce her, who is also my PhD supervisor. So she is Emeritus Professor, Educational Sciences. Her research interests regard development, maintenance, improvement, and innovation of professional expertise and the conditions that support or hinder that. Apart from research into educational measures and structures that can optimize these processes, she studies effects of change in society and individual and collective adaptive processes. Professional domains studied are teaching, medicine, and other healthcare sciences, psychology and counseling, business, and architectural design. She published over 250 articles and book chapters on these topics. So then the topics, I hope you would be telling the topics as you go on. So please, over to you. Thank you very much for accepting our invitation and speaking today in this symposium. Over to you.
Thank you very much, Kosala, and a warm welcome from the 4 speakers to all of you present today in Zoom. My name is Renee Stalmeijer, as Kosala said, and I'm going to share my presentation with you right now and make sure that's on the first slide. So, like Kosala said, what we want to talk to you about today is the potential of interprofessional education as a way to better prepare our healthcare trainees for future practice. And there isn't a policy document or a researcher that does not feel that safe, effective, and sustainable healthcare requires interprofessional collaboration. The World Health Organization defines interprofessional collaboration as multiple health workers from different professional backgrounds that provide comprehensive services by working with patients, their families, carers, and communities to deliver the highest quality of care across settings. But is interprofessional collaboration something which we can expect to naturally occur? And I think that the healthcare professionals present here today know that this is not always the case. And as such, there has been a strong push during the last 2 decades, to introduce interprofessional education in the more uniprofessional educational curricula. So the idea is that we prepare our healthcare trainees for interprofessional practice by an educational model, IPE, that aims to educate them to be better collaborators by enable them to learn with, from, and about each other. Now, what should we think of when we say learn with, from, and about? So assumptions underlying IPE is that by collaboratively solving healthcare issues or real life problems, that you learn from the others and expand your own professional competence while building on the competence of others. So how does my competence align with your competence? And we also want our students to learn about their own beliefs, values, and knowledge base, but also that of the other. So where does my knowledge end? Where does yours begin? And how can we together provide effective and safe patient care? Now, although everyone agrees that IPE is very necessary, unfortunately, we also know that it's not very easy. Think about it. You're a director of a medical program. You have to align your program with that of the nursing school, physiotherapy, dentistry, midwifery. It's logistically complex and costly. And the educational interventions designed up to date are often not very structured and not informed by educational theory, because the main idea is, let's bring them together. And if we bring them together, they'll learn. But what we know now, after several decades, is that just bringing them together is not enough. Furthermore, it's a very difficult role for teachers because they have to engage with learners from different professions, potentially different levels of training. Not all educational programs align, have the same entry points. So for them, it's difficult to manage this. And IPE is rarely addressing issues of hierarchy and power. Now, healthcare teams naturally have a certain level of hierarchy, and it's necessary. But sometimes that hierarchy actually hinders collaboration. and power issues might thwart it even. And it could be culturally exacerbated, these hierarchical and power issues. So in some, IPE is not easy. So it's not easy, but it doesn't mean that we don't think it's a good idea and that we can improve it and see different ways of how to optimize it. So today's program consists of 4 presentations to explore just that across the continuum of health professions education in the undergraduate setting. So Endang Lestari will start us off in a minute by talking about her experiences in implementing IPE in Indonesia and studying that empirically. Then my colleague Jascha de Nooijer will use landscapes of practice to explain a potential design for IPE. I will then follow, taking us into the workplace learning bit of the curriculum and talk about why I think that we need to also see workplace learning as an interprofessional endeavor. And then finally, my colleague Els will talk about learning to understand and cooperate with other professions, novices in an interprofessional workplace. During this symposium, we would like to interact with you, but we have a couple of rules. So if you have questions, please use the chat. Don't unmic, use the chat. And if you have a question specifically directed to one of the presenters, please use the @ and the first name of the presenter. So @René, @Endang, @Jascha, @Els. These questions will be addressed collectively after the presentations. And after the presentations, we also would like to discuss with you. And for that purpose, I have prepared a WooClap. And I would like to ask you right now to either use your phone and scan the QR code or go to www.wooclap.com/Colombo, capitals, 2021. So if you could take a second to go to this site, then I have a couple of warm-up questions prepared for us. So you scan the QR codes or go to www.wooclap.com/Colombo 2021. No. So I'm going to go to the next slide. Don't worry, the link will still be visible. So first, I would like to get a sense of who is in the room with us. So I would like you to answer the question, how do you identify professionally? And for the people still trying to join, please go to www.wooclap.com/Colombo, capitals, 2021. So far I can see that 4 out of 5 out of 8 people have answered that they identify as physician, allied health, basic scientists, and educationists. keep going until everyone's in the room. So if not everyone is in the room, that I can see that all the professional identities are covered, but I'm not sure if we're going to make that today. So while the others are still trying to get online at www.wooclap.com/Colombo 2021, I'll move us to the next question. Which part of the health professions education continuum do you mostly work in? So is this undergraduate, preclinical, undergraduate, clinical, postgraduate, workplace education, postgraduate, formal education, continuing professional development, other, or none of the above? Okay, so we have a nice spread across the continuum present here in the room. Okay, so this was our trial run with WooClap. We will be revisiting WooClap after the presentations. But for now, I'm going to stop it. So don't go away from the website. We'll come back to it later. I then will also again announce the www.wooclap.com/Colombo 2021. But for now, I would like to move us to the first presentation by Endang Lestari. So Endang, I'd like to invite you to share your screen.
Okay, thank you very much, Renee. I'll start the screen. Is it good?
Yes, we can see it's very good.
Well, thank you very much, and good afternoon here, and good morning in Netherlands. Renee previously has explained about the importance of interprofessional education to improve collaborative skill of our health professional students. And now my duty is explaining our experience in implementing IPE. We started implementing IPE since 2017. And hopefully this information will become an inspiration for other institutions who want to initiate the implementation of IPE. Well, what should be considered when we want to implement the IPE, because there are so many issues that need to be considered, such as we have a problem with leadership, and then curriculum, resources, and logistics, teachers and students' perception toward IPE, and then role model in hospital and public health center. All of those issues should be addressed to make sure that IPE program will be sustained. Related to leadership, we know that poor planning, coordination, and organization are common problems faced by institutions when they want to implement IPE. And in my institution, regarding this issue, our institution developed interprofessional collaboration and education center in the university level to organize the IPE program. It's a Faculty of Health Profession Education in our institution send their IPE champions to the Interprofessional Collaboration and Education Center, where, as I said, that it is on the university level. And there are 3 departments in the center. We have curriculum department, logistics and facilities, and also faculties and students coordination. And each of the department has their own specific roles. Curriculum is another important issue to deal with. As normally, health professional school has their own established curriculum, which are quite packed and inflexible, we know that. And we also face a problem related to schedule. Scheduling is another issue for IPE. And we also face that, particularly on the first time when we want to implement IPE. We have to struggle a lot with the scheduling. As we know that there are so many education formats for IPE, we learned that we can use case-based discussion, problem-based learning, clinical skill simulation, and others. And these are the education formats used for IP and which is implemented in our institution. We use problem-based learning, and then we also use simulation. We use community-based interprofessional education, and we also implement work-based learning in hospital and public health center. During the preclinical year, RPA activities are embedded at these modules. In the old semester, we have cardiovascular system, respiratory system, reproductive system, and emergency. In the even semester, we have psychiatry, family planning, and then a community-based IPE, which is in a clinical year program, and IP and the public health center also in clinical year program. And this is the example of case scenario that we use during the respiratory system module. And based on our experience, the most important thing to consider when we want to develop case scenario for interprofessional PBL are involving teachers from some health professional background, and the scenarios should address learning outcome of each program. Besides that, the scenarios should also use common language and term, which will be understood by students of all program, and the scenarios should include discussion of role. This is important. So discussion of role should be there within the scenario so that the student will discuss that. And this is the finding that we have found from interprofessional PBL. Within the interprofessional PBL, we learned that group members from different professions complemented one another in solving learning issues. They also learned from each other professions. They did correction of misunderstanding without causing offense. However, the role of tutors, social and cultural values affected student perceptions because asking critical questions is not always self-evident, and the students still persisting professional barriers during the interprofessional PBL. And within the community-based interprofessional program, we include medical, nursing, and midwifery students. They have to take part the IPE program, 1 week classroom training. And then after that, we send them to the community. Yeah, we let the students have a community engagement. And there in the community, they have to do some activities such as surveys, discussion, and then conducting intervention program. And then they also do evaluation and reflection activities. And these are the pictures that describe some of the activities within the community. Resources and logistics is another issue that must be taken into account, I think. For example, in our experience, we have around 100 students from 3 programs involved in the IPE program. Let's say from medical, and then nursing, and then pharmacy programs. Of course, when we have 400 students, we need at least 35 classrooms for small group discussions. And then we also need 35 tutors. That's a lot of things to prepare. And the other problem will come up when the teaching and learning activities is simulation. Simulation with patient, with standardized patient and mannequins. That will be much more difficult for us to deal, because we have to prepare 35 set of mannequins and the equipments, and then we also have to prepare 35 simulated patients. but a lot of things should be considered. That's why resources and logistics department is the most busiest department within the center. We know that faculty members plays very important roles in IP implementation, since they have to develop curriculum and they also have to become the facilitators of the teaching and learning activities. So for that, we do faculty development programs on IPE, and we do that prior to and during the IPE implementation. And students also play a very important role. When they have negative perception toward IPE and IPC, they will not be motivated to actively involve in IPE program. Therefore, we do some activities such as uni-professional training on the importance of patient safety and IPC and the need of IPE. And we also do interprofessional extracurricular students activity. Hopefully by doing this activity, we hope that the students can work together and then can collaborate before they come to the classroom. Role model is also important, very, very important, because the students will learn from them. We know that health professionals in the hospital and public health centers are best role model for the students. Therefore, they have to become role model for the students to promote the culture of an interpersonal team collaboration in the workplace. Therefore, what we do so far, we conduct training on IPC for clinical teachers in our teaching hospital and also public health centers. And we conduct training on developing interpersonal clinical pathway for some cases in hospital and public health center. Hopefully by doing that, we can motivate the health providers in the hospital and public health center to collaborate well. So this is my position. The successful and sustainable implementation of IPE should be the responsibility of all health profession program involved, and therefore logistic and financial resources should be shared evenly among the programs. That's all my presentation. And this is my practical experience in initiating the implementation of IPE. Hopefully this could give inspiration and ideas for other institutions when they want to implement IPE. If you have further question, you can come to, you can send me email related to this. Thank you very much.
And then could you just go one slide back to your proposition? Then I can explain what we expect from the proposition. Okay. Because after each presentation, dear audience, you will find a proposition that the speaker has thought of. And we would like you to react on that later on via WooClap. So, and then the proposition is that the successful and sustainable implementation of IPE should be the responsibility of all health profession programs involved, and therefore logistics and financial resources should be shared evenly among the programs. I also want to remind you that if you have questions, please post them in the chat and start your question off with @ and the name of the presenter so that we know who we can address the question to. Thank you very much, Endang. I would now like to give the Zoom to Jascha de Nooijer and to talk about landscapes of practice. So if you could stop your screen share, thank you. And Jascha, go ahead.
Is it clear for everybody?
Yeah.
Okay, thank you very much. Thank you very much for the invitation. Good. And I would like to reflect on how theory can inform the design of interprofessional education. And I think that many of the things I will say in the next 10 minutes resemble what Endang already told, and she applied that in interprofessional education. And I would like to have a more theoretical view on the aspects in interprofessional education. So As Professor Kosala already mentioned, today's societal problems are complex. The population is aging, we live longer, but we also face more chronic health diseases, and the onset is at an earlier age. And also the existence of health inequalities exist, so caused by differences in the environments where we live. And the final thing is that the combination of physical problems with mental problems or social problems causes more complex problems, and they require multiple perspectives and collaboration by various professionals in the healthcare in order to solve them. And in addition to changes in health-related problems, there is also a change in perspective on how we look at health. Whereas we used to think based on the biomedical perspective that health is the absence of disease, and when we become ill, the solution should be a medical treatment, we now think that biological, psychological, and social factors and their complex interactions are responsible for health and illness. And that means that solving such multidisciplinary problems also requires a multidisciplinary approach. So in the biopsychosocial perspectives, we consider health, disability, functioning, and quality of life. And let's give an example on how a complex case could look like. So meet Mrs. Jones. She is 74 years old. She's married and she lives at home. She suffers from diabetes type 2 and she also has complex COPD. And recently she was admitted to the hospital with a diabetic foot. Now she's going back home temporarily with a wheelchair. And you can imagine that she frequently visits and consults her family doctor, the diabetes nurse, several medical specialists, a physiotherapist, a dietitian, etc. These professionals should collaborate in order to develop a care plan for Mrs. Jones. But do they collaborate successfully? Is the plan aligned? And is the collaboration aligned so that Mrs. Jones receives the care, the best possible care for her complex situation? So we think that by better preparing future healthcare professionals, we can better solve such complex cases, because Mrs. Jones is not the only one. And IPE can be a solution. But one factor that hinders the success of interprofessional education is professional stereotyping due to socialization processes in one's own profession. Each profession has their own beliefs and attitudes towards their own and other professions based on general assumptions, and Dang already mentioned that. And to avoid the stereotyping and subsequent consequences for patient care, we should do more than just bringing students with different backgrounds together, because this does not automatically lead to better collaboration, open attitudes, and respect for other professionals. So we have to do more to enable students to discover their own professional role and responsibilities, and that of others, and how their work can be aligned. So I think this can be achieved by the identification processes that are addressed in the theory of landscapes of practices. The landscape of practice is a metaphor for different communities of practice. For example, you see on the left-hand side, the nurses, or on the right-hand side, the doctors, and the boundaries between those practices. And the key concept is knowledgeability, which refers to a combination of competence and identity. And we think competence is being competent in one's own professional community of practice. And a knowledgeable professional is able to move through the landscape and collaborate with others. And this implies that building relationship between members of different disciplines should be an implicit aim and a starting point of interprofessional education. And therefore, learning at the boundaries of different professional practices should be facilitated in order to get a clear picture of your own role, the role of the other, and how you could contribute to interprofessional collaboration. And in the next slides, I will show you how I think that the process of identification can be used in interprofessional education at the undergraduate level. So the first mode of identification is engagement. In their own community, competence is enhanced by working, learning, doing, talking, and debating together. Engagement in IPE means that when moving through the health landscape and collaborating with others, we should know ourselves and others and how we are relevant to others. This relates to working on issues in one's own practice through complex, authentic tasks that resembles real life. Remember Mrs. Jones. In discussing the care plan for Mrs. Jones and her transfer back home and follow-up care, the team experiences that comprehensive care plan requires input from and collaboration with various professionals. So in IPE, a relevant task could be, what you can read in the orange box here, describe how and what you can contribute to best manage Mrs. Jones' transfer back home and aftercare. And more importantly, maybe listen to your fellow students and then describe what you and the others can contribute and how you can coordinate the contributions in order to develop a care plan. But repeated engagement is needed. A single meeting to discuss a case will not be enough to become a knowledgeable member of the landscape. And more cases that gradually increase in complexity to enhance transfer for practice and to learn from, with, and about other professionals. That is the first mode of identification. The second mode is imagination. Imagination refers to how we see ourselves in our role and how we see ourselves in relation to each other. For IPE, that means that when we meet others we do not know yet in the health landscape, we should learn what we are doing in the landscape and how this relates to the others. So awareness is very important here. Think of Mrs. Jones again. The dietitian, for example, will approach Mrs. Jones differently compared to the physiotherapist. Most likely, the physiotherapist would like Mrs. Jones to get active again after her foot operation, while the dietitian will adapt her food intake during her renewed activity pattern because she's now using a wheelchair and maybe less active. Both professionals should collaborate in order to develop a comprehensive care plan that helps to improve her functioning and quality of life without interfering other aspects of the care plan, for example, medication. Students should be invited to reflect on their role and responsibility in such cases. So it could be a learning activity could be that they reflect on what are my roles and responsibilities and what are the responsibilities of other professionals and how do we matter or relate to one another. So it is very important to enable reflection on these aspects in interprofessional education. The final mode of identification is alignment, which is a two-way process of coordinating the collaboration so it has the effect we expect. In our case, better healthcare and preferably by involving the patient or the client. In our example, that means that students from different backgrounds collaborate successfully in helping Mrs. Jones transfer back home, in keeping her diabetes under control and managing her COPD. All involved need to understand and speak the language of different professionals and the various systems in which fellow professionals work. All involved also need knowledge of the system and context in which professionals collaborate. And this requires a safe environment in which students feel free to speak, ask questions, and show respect for other perspectives. This also requires more than one meeting and a real-world context, so learners can gain understanding of how their different professionals align with each other. So we see knowledgeability as the goal of IPE. And I see that developing knowledgeability as the goal of IPE is facilitated when the three modes of identification coexist in undergraduate education, and they should coexist in balance. So what we recommend is a longitudinal learning trajectory featuring a series of authentic cases to practice every time the three modes of identification. Deliberately enable students to reflect on their identity, their roles and responsibilities, and encourage them to imagine who they would be in their future professions and discuss that with each other. And in the design of the learning trajectory, also students should be encouraged to collaborate with their peers in other professions in the context of the healthcare system to gain a better understanding of the importance of building trust and respect for one another, and in order to align and collaborate successfully. And this all cannot be done without a proper teaching or staff development program, because Endang already mentioned that teachers have a different role. They are a role model, but they also need different skills and competencies to be that role model for their students. If we do so, we strive to collaborate effectively in order to improve the health and healthcare of Mrs. Jones and others. So that's my, sorry. It's not working. There's my proposition. So although there is debate when you should start with interprofessional education in undergraduate education already, I think that professional identity formation should start in undergraduate education, so as early as possible in health professions education. Thank you for your attention.
Thank you very much, Yasha, for that very interesting presentation. We welcome questions for Yasha in the chat by starting them off with @Yasha. And I now will go back to sharing my slides again, because now it's my turn. And I will be building on the story of Yasha and also using the landscape of practice as a theoretical lens to look at this issue, because I think we need to challenge the current intra-professional workplace education norms. And I'll explain to you what I mean by that. So an important part of the health professions education continuum is situated within the workplace. We invite our healthcare trainees to work alongside healthcare professionals, learn from them, situated in everyday clinical practice in a variety of healthcare settings. And when we try to understand how learning in the workplace and specifically in the clinical workplace happens, a lot of researchers favor socio-cultural learning theories as a lens. And socio-cultural learning theories depart from the idea that learning occurs through participating. So through activity with others, you learn, and you learn to become the competent person in that environment. And that means that since participation is fundamentally social, that your learning happens through the relationships that you engage with in that setting. So for the medical trainee, we can think about the residents there, the attending physicians there, but also their peers who are there simultaneously, and the members of the healthcare team. We do need to consider, however, that learning in the workplace is often informal rather than deliberate and formal. It's very much dictated by the needs and the occurrences in the clinical workplace, because workplace learning is driven by the needs of patient care and not student learning. And what we also see is that participation is progressive, meaning that as you become more competent, you will get more autonomy and exposed to different types of learning experiences. So to explain this, communities of practice has often been used as a theoretical lens, but has also been described as the vehicle through which you learn and the goal that you're trying to attain. Because, and in my examples, I will specifically talk about the medical profession, because becoming a competent medical professional can also be described as a trajectory, which means that through legitimate peripheral participation, students will get new learning opportunities within a certain setting, and you become a legitimate peripheral participant by demonstrating that you speak the language, that you have the shared repertoire, that you know how to behave in a certain setting. And you develop this by guidance from more senior medical professionals. You develop this competence by mutual engagement in patient care. So you will collaborate together with the others to provide patient care. And if you are successful in your trajectory, you will move from the legitimate peripheral participant into the community of practice. And if you attain that goal, you have become a full-fledged member of that community. You have become a physician. But like Yasha was already talking about, which healthcare communities do medical trainees actually need to be legitimate peripheral participants to and become a part of? And who can provide them with that access? So I think that the field of medical education thus far has been very much focusing on that trajectory into the community of physician practice. So specifically doctors, more specifically often specific disciplines, right? You become a pulmonologist, you become an oncologist, you become a dermatologist. You move into that specific community of physician practice, and that's what your trajectory is geared towards. But I would like to make the case that we actually need our medical trainees not just to become legitimate members of that community of physician practice, but at the same time of the landscape of healthcare practice, where the different types of communities of the different physicians, but also allied health, nursing, all collaborate together with the shared goal of providing patient care. So landscapes of practice as a theory is kind of an evolution of the communities of practice theory. It comes from the same author, Wenger Trainer, and he talks about how when we just look at the community of practice, it's too singular, it's too limited. So he says that if we want to understand how we learn and practice and what competence means in that setting, that we need to look at the landscapes of communities that are brought together by a shared purpose and not just that one single community. So in the case of healthcare, it's very easy to imagine that healthcare is a landscape of communities brought together by the shared purpose of providing safe and effective healthcare. So actually, what we need our medical trainees to do is to become the physician member of the healthcare team. They need to understand how to actively engage with all the others. They need to learn to interact with the various communities that the landscape of healthcare practice has. So therefore, instead of talking about becoming a competent medical professional, we need to see it a little bit broader. We need to be talking about becoming a competent healthcare professional. Our trainees need to develop shared understandings of the goals, repertoire, skills, common language and resources shared within that community. They need to understand roles, their own role, the other roles. Where does my role start? Where does your begin? And they need to understand what is required to be an effective physician member of the healthcare team. Because what we want to happen is that they start to be recognized as a reliable source of information within the landscape of practice within the healthcare team. We want them to become a knowledgeable member of the community. So in order for that to happen, I feel that we need to move away of the perspective we've held so long that we teach our own. Doctors train doctors, nurses train nurses, physiotherapists train physiotherapists. I think we need to have an interprofessional approach to workplace learning, which means that it's not just the doctors training the doctors, but that all members of the healthcare team have a valid role in defining what competence means, assessing that competence, and guiding the learning trajectories of our trainees. And there are already several empirical examples of this interprofessional approach. We know of examples where competence of a trainee is perceived very differently by different members of the healthcare team. We also know that all members of the healthcare team are continuously assessing a trainee's competence, their attitude, what their intentions are. Are they just rotating through? Are they really wanting to become a part of this community? And we know examples of clinical teaching. For example, Mara Polanski looked into how physician assistants guide the learning process of medical residents. But why then do I feel the need to challenge the current intra-professional education norms, where it seems very natural to say that if you become a part of a team, that all the team members have a role in helping you to attain competence? I feel that medical education as a field has very much been enforcing these intra-professional norms, probably inadvertently. Because what we do, but also how healthcare is organized, means that there is a lack of formal recognition of the role of the healthcare team in interprofessional workplace learning. And I think that this absence is unintentionally maintained by professional autonomy and role boundaries, power and hierarchy issues within the healthcare team, and some problems with mutual credibility. And what Endang and Yasha already underlined is the importance of role models, right? If we learn through participating, that means that we're socializing into a certain environment and that we socialize into a certain way of thinking and feeling. And unfortunately, students are not inoculated to the bad role model behavior with regard to interprofessional collaboration and practice. We can train them a lot in the undergraduate setting, but if they're exposed to a workplace setting where interprofessional collaboration is not valued, then it becomes very difficult to make a change. So what I think is needed to bring this interprofessional future to fruition is that not that we don't only see healthcare as a team sport, but also learning to become a healthcare professional as a team sport. So we require input from all members of the healthcare team in defining competence, in assessing competence, and in guiding competence development. So therefore, my proposition for today is that the field of medical education needs to actively challenge the current intra-professional workplace education norms. And you can read more about it in this publication. So thank you. And now I would like to give the floor and the screen to Els Bos.
Thank you, Renee. I'm trying to share my screen. Yeah, I think it works. Listening to the others, I was thinking about the overlap and what my contribution to the discussion of today is. You might see it as a way of looking at the problems that a student, it can be a medical student, it can be a student of other professions in the team, but the student, because of being a student and because of not being fully developed as a professional, have when they enter the workplace and the problems they have with workplace learning. My co-author is Tuire Palonen. She's from the University of Turku, and she's the one I have discussed these issues with quite often. I can go. I have to proceed this way. The precise title of my presentation is Learning to Understand and Cooperate with Other Professions, Novices in an International Workplace. So the focus is on what does it make to be a novice and have to learn in an interprofessional workplace. This is discussed quite by I think everyone using different pictures, but we are talking about workplaces with different professions, but having one goal with interdependent subtasks with different responsibilities to fulfill these tasks that have to be coordinated and that they have to carry out in a well-prepared way. The operation theater is a very orchestrated kind of cooperation, but there are many other situations where interprofessional work in the workplace is required. And I think that, and Dang also already referred to that by talking about community care, in which also all these people, different professions cooperate, but in a more loosely coupled way. So this summarizes it. We have professions. There's a little problem, and that is that in the top of the screen there is a little figure now that might be covered by the faces of presenters and others. So if you are missing that, it will be enlarged.
You can see it else.
We can see it
else.
Yeah. Okay, so I'm the only one who does not see it. When talking about full-blown workplaces, we can use this 4C model in which the context in which the work has to be done, the colleagues the work has to be carried out with, the conventions that they use to orchestrate the ways of working together, and the capabilities of the different professionals have to be in tune. Now, the novice who enters this workplace brings some capability to that workplace. And that even is not full-blown when they enter there as a novice. So they have to learn, not the whole thing, they still are novices, but they have to get at least a good idea of what it means to take the next steps of participation in these workplaces. Now, what do novices bring to that medical workplace? When we talk about medical students, they bring some, or maybe a lot, it depends on the stage of their training, of course, medical and clinical knowledge. They can bring dentistry knowledge, they can bring nursing knowledge. They bring their reasoning skills, they bring the learning skills that they have used to build up this knowledge and skills. They have general soft skills, interviewing, etc. And they have multiple identities, the identity as a student and their identity as a developing professional. I will focus on these three elements: the knowledge they have, the reasoning skills they have, and the associated learning skills. And they are the basis for learning in the workplace, but it can also hamper their learning. And that's, I think, that my main message of today. And I'll also talk about how we can try to overcome that. So starting with the knowledge and reasoning that the students bring to the workplace. A novice does not have complete knowledge. We know that their knowledge is fragmented. It's in different topics, different domains, and it has been taught in different stages of their training. the knowledge is incomplete and they have misconceptions, as Dr. Kosala and I published about. And their knowledge is compartmentalized. They know this is about internal medicine, so I have to talk about that. This is about specialized nursing, so and they are their curriculum is organized that way, and their testing is organized that way. So they even try to defend interactions between these knowledge systems, because in test situations they might be punished for that. To apply that knowledge, they can only use step-by-step reasoning, and that means that they activate one concept, like when we are talking about Mrs. Jones and their amputated toe, that activates other concepts about the process that had led to that situation of their toe. It can activate new other concepts about the other kind of problems that this person might face, like eye problems. Being a novice means that you do this step by step. It's not something that is immediately apparent for the well-trained eye. And this step-by-step reasoning requires mental effort and leads to what other researchers call cognitive load. And a loaded system prevents that you can also give attention to other kinds of information. So taking a next reasoning step cannot be done by a student themselves, but needs cueing by their supervisors or by other students. That's not so important who does that. So this cognitive capacity is not available for other inputs and for other thoughts. And students also have difficulty to think on their feet. They have to stop and think. They cannot take action and immediately, and they cannot think during interaction or during history taking about what options might have to be explored. They have to stop and think, and they cannot think beyond their own perspective. So this is the perspective taken, but how would that be tomorrow would be difficult, but even more how other professions can look at that will be very difficult for them. So this clinical, the structure of their knowledge and the amount of knowledge they have is not enough and takes so much effort that learning in new situations cannot be used to the full potential. And there's another thing that is making learning difficult for students in the workplace, and that is they have developed their learning skills in learning from books, learning from videos, learning from the other materials that is available for them, and by being trained in skills labs or in school, in woodworking labs or whatever. But learning from experience is something different. Learning from experience is not, and that resonates with René's remarks about the model of participation. The participation is not what students learn from, but it requires more. The experience is not what the students learn from, or they do learn from experience, but using it to the full potential needs that they reflect on their learning. And that's a statement from John Dewey, who built a whole educational system based on learning from experience. So what students have to do to use the full potential of the experience is, in advance, what am I going to learn? Ask themselves, how and from whom am I going to learn that? And that's where the multiple professions come into place. What kind of actions are suitable to learn from? And afterward, how successful was that? And that can, again, lead to new cycles of learning. Now, this is a model that is, I think we try to train students also this reflection model in preclinical stages, but they do have difficulties with that, or they even hate that. So they need to be supported by while doing that. There's another thing that we must be aware of as teachers, and of course we know that novices are not the same. They do bring not enough knowledge to the workplace, but the amount of knowledge and the quality of their knowledge is very different. The motivation and learning skills are very different. Their ambition is very different, and the beliefs about learning can be very difficult. So Ria den Hertog and myself did a study with nursing students, and we found that their beliefs about learning in the workplace varies a lot. Some of them say you can only learn from practice, sort of even trying to step away from the knowledge that they had learning, seeing that themselves as hindering their learning. Some of them say, well, you have to look at knowledge just in time, that's most efficient. Others say practice contradicts theory so often, so why learn theory? And saying they have want to have an open mind in learning from experience and learning from the workplace. And they are all images about learning and experiential learning that sort of put the knowledge aside as something that is not useful, that hinders them. And by doing that, they do not use the situation to improve their knowledge and to check out their understanding and build up their skills from build it up based on what they had learned in school before that. So we saw that the students who did these things, did prepare, did try to imagine what they knew already and how they could use it, and much more came up with much more learning and better learning outcomes than the ones who had the kind of beliefs that I just showed you. And that leads me to my statement for today. And that is that all workplace professionals should scaffold students' experiential interprofessional learning with questions regarding what, where, how, and from whom, and did I questions. Thank you.
Thank you very much, Els. Also, for Els, we welcome questions in the chat. And it's now that portion of the program that we will address some of the questions in the chat. And the first question asked was by Sisira Dharmaratne. Sorry if the pronunciation is way off, but it's for Endang. And Sisira writes, nice work, more on drivers behind such a well-organized IPE program. So could you say a little bit about what you think, Endang, are the drivers behind the success of your IPE?
Yeah, thank you very much for the questions. Actually, leadership is very important here, and the leader, I think, the dean of faculties of health professional education faculties in our institutions. We have a faculty of dentistry and then faculty of medicine with some programs there, and then we also have a nursing faculty, and all of those deans very supportive, I think, because without their support, I'm not quite sure that IPE can run well. We need quite a lot of funding to run these resources, funding and others. And yeah, without their support, I'm not sure that it will run. So leadership is very important here. That's the first. And then the other things lately, since 2020, if I'm not mistaken, the quality assurance body in our in the higher education here in Indonesia require all of the health professional educations to implement IPE, and they evaluate that within the item or the standards in the quality assurance. So it means that since 2020, all of the health professional educations in Indonesia should implement IPE. Although it is quite difficult for us, probably for some schools to implement IPE. We know that the problems, quite a lot of problems with that, and but because it is required by them by the accreditation body, then yeah, they have to do that.
That supports it, yeah. Yeah, and another question for you was by Ranjani Netasinye, and they write role modeling. Is it a very important aspect for IPE or not?
Yeah, of course, it is very important aspect. Like what Renee mentioned, and also Yasa explained, that students will be very influenced by how the health patients in the hospital work together, collaborate. So one of my experience with the students before we implement IPE, we did a kind of survey to the students and related to their perception toward IPE. It is very interesting that students who have ever engaged in a clinical setting, let's say in that case, nursing students, yeah, they got the clinical rotation before, although they are in the undergraduate, but they have clinical rotations, and they have negative perception toward collaboration, interprofessional collaborations. Why? Because they see how they saw how the health professions interact in the hospital. They don't. They are very pessimistic with the interprofessional education. They said that it will not change anything. They said that. Although we did the interprofessional education, we collaborate with students, with other students in undergraduate program. But when we come to the hospital, they said that when we come to the hospital, we will change because the culture is not that good for us to collaborate. They said that. So I think role model is very important here, particularly health professions in the hospital or in public health center. They should become a good role model for the students in terms of collaboration.
Okay, thank you. There's also a question in the chat for both Yasha and Els. So I'll read it out, Yasha and Els, and then I'll ask you to comment. So Cicera again asks if undergraduate students are constrained by the cognitive load, limited workplace-based experience, and diversity in their learning needs, is it fair to consider that IPE is more for continuing professional development and postgraduate contexts rather than the undergraduate contexts? Yasha, what's your thought? And then I'd like to hear from Els.
Well, thank you for that question, Cicera. It's an important question, and I'm not sure if we already know the answer based on the researches that I've done so far. But what I propose in my presentation is that we should start early to expose students to students with other backgrounds and to reflect on their own role in healthcare and their responsibilities, and also to see and experience what other students, what other roles and responsibilities are. So despite a lack of work experiences, which is very important, and I think Els will also agree with that, I think it is important to start early because then you still have students with open minds. They are not yet fixed in their own community of practice, I would say, in their own role as a doctor or as a nurse. So they're still open to other professions and other responsibilities. And as long as the goal is a shared goal, they can work on that. And you should start, of course, with simple cases and simple assignments, but gradually increase them in complexity. But I think you can start in undergraduate education. And I hope to do research on that within a year. So I can inform you maybe after 1 year.
Or in a year or two, but that's
Yes.
something nice to look forward to. Els?
Yeah, I completely agree with Yasha. My story about fragmented knowledge and problems of reasoning on your feet in workplaces is of course based on the present day experiences with how curricula are built up. We first train them or try to train them to be to have the knowledge and skills that might be expected from them as future nurses, physicians, etc. in the workplace, like what Renee was also talking about, neglecting all the other elements of what is taking place in the workplace and how the work is done. And I think that many students are in a way not very much interested in these questions at the moment. And it's just like going to school, you're not interested in what the director in schools do as a student. And as a student in the university, you have the same identity in the beginning as being a student who has to learn to get the essential of the job disregarding all the other elements that are also very important, and taking off the blinkers and helping them to see themselves in the wider perspective in the future can only help them to visualize how they are going to work in the future. Not preloading them with lots of possibly required knowledge, but starting at a very early stage can help to build that perspective before stepping in with the cognitive load that we now require from them.
Yeah, I see what you're meaning. It is, I think we sometimes forget how overwhelming the clinical work situation is for novices, and that they are expected to think on their feet. Even the other day I had a meeting with a supervisor who said yes, and then they didn't study what I asked them to study, and so they must not be interested. And I said, did you ever consider that they might be overwhelmed with all the other things that they're trying to study up on? And he went like, oh, no, did not consider, but yeah, you might be right. So yeah, not losing track of the novice is important, I think, yeah.
There's also a question for René in the chat, and that question sounds: how far interprofessional education interventions have impacted on interprofessional collaboration during clinical practice and care received by patients? René, can you reflect on that?
Yes, I can. I can reflect on that by saying that it's the links, of course, between educational intervention and then actual behavior and practice and patient outcomes is, of course, difficult to study. But we know examples of how interprofessional collaboration has positively impacted interprofessional collaboration and also patient outcomes, although not in very many settings yet. So we know a lot of evidence on this in the primary care setting. So in the Dutch setting, that would be the general practitioners, more community-based care, and not so much hospital care. So the very direct relationship is difficult to measure, but there are some examples still. But one of the arguments for why it is difficult to measure the impact of something which happens in an undergraduate setting to something that then needs to be applied later on, is that there are so many other things happening in the meantime. And one of the critiques actually on IPE is that it does not make sense to do it in the undergraduate setting because students are not ready. They're not ready from a knowledge-based perspective. They're not ready from an identity-based perspective. So it just has too few hooks to link onto in their minds, and that it starts making more sense as soon as they hit clinical practice, because then they need to apply, then they know that they're very much dependent on all the other professionals and that they will not reach that goal of safe patient care without involving them and working with them successfully. So no straightforward answers, positive signals, but complex nevertheless.
Yes.
For time's sake, thank you, Jascha. I would like to see if we still have some people on WooClap, because we left you hanging with the propositions. So I'm going to share the WooClap again. And if you had not yet joined in, please go to www.wooclap.com/Colombo Capitals 2021. And there you will see now, hopefully, this proposition, the proposition from Endang, and that reads: the successful and sustainable implementation of IPE should be the responsibility of all health professions programs involved, and therefore logistics and financial resources should be shared evenly among the programs. So I'm interested to see how the audience feels about this. Okay, so we have 3 people in favor. The successful and sustainable implementation of IPE should be the responsibility of all health professions programs involved. and therefore logistics and financial resources should be shared evenly among the programs. Can I get some more votes? I can make available the link in the chats. Wait. So out of the 13 people, 4 have voted and 4 say to agree with Endang's statements. So you agree that we're all on this together and we all need to carry the weight. Hoping that more people will join, but for time's sake, I'll move on to the next proposition. Professional identity formation should start as early as possible in health professions education. How do you say? Also here, thus far agreement in the room. Yasha, start that intervention.
Luckily, thank you.
Someone neutral.
Oh, someone.
Very good. Keep us on our toes. Doesn't have to be
Who's
all
that?
rosy. Good to see more people voting. Still strongly ahead on the agree, Yasha. Okay. Moving on, I appreciate that some people might have internet issues and that this is not going as quickly as I'd hoped. So my proposition was the field of medical education needs to actively challenge the current intra-professional workplace education norms. We have an important role in this, is what I say. And 5 of you say also. I think this is something we can more actively push for in our research, in our educational design, and how we think about problems. So I agree that 9 of you agree with me. Happy to see that. Neutral.
Someone's neutral.
But one more voter, so we're now at 10, so that's good. Okay, for the final proposition, and then I have one final question before I leave you. Elsa's proposition that all workplace professionals should scaffold students' experiential interprofessional learning with what, where, how, from whom, and did I questions. And we're talking all workplace professionals. Slowly moving up. One disagree.
Oh,
Okay.
The problem
So,
is, of course, how to organize that.
yeah, but that's
To facilitate that.
absolutely.
Yeah.
So I think that with all our presentations today, we hope to have whetted your appetite for interprofessional education and demonstrated its value for better preparing our health profession trainees for future healthcare practice. And of course, there are many challenges left, but I think it's worthwhile to take on these challenges and to collaborate in doing that. So my final question for you is, what are your take-home messages from this symposium? Teamwork. Role modeling in the workplace could make a change. Absolutely. Interprofessional education is very much needed in Sri Lanka. Need more research in it. Yes. Start thinking about how to do that today. IPE more needed in clinical settings. Yes.
yeah, great.
Oh, Professor Pereira's wanting to draw. Okay, so I'll leave this active. Attention has to be paid on interprofessional and interprofessional education for the healthcare. I'll leave this active so that you can still feed us with more answers, but I would also like to show you, let me see, where are we? This final slides. Namely, that I want to thank you all for your participation today and for your questions and your participation in WooClap. We enjoyed organizing this symposium for you. If you want to learn more about the different things we talk about, you could consider looking up these references. And in the meantime, from the Netherlands, where the COVID situation is not great, I wish you a lot of health and stay safe, and hope to see you sometime sooner rather than later across the globe. Take care, everyone.
Thank you. Thank you, Rennie, for those kind words and also the wishes, and we wish you the same. So all over the globe, I think we have to wish everybody a safe time. And thank you very much for all the effort. And we could see how organized you all were. And right from the start, from the day we invited you, you were enthusiastic, all of you. And so I think you have generated some interest on the topic. And I had to tell today the participation was not that great because there are two conferences in Colombo. So I received some excuses from some of them who had to attend those conferences as well. So this seems to be the month, the conference month, right? And so I hope you have consented, and the recording would be available for those who would like to listen later. And thank you very much for raising these issues. And it's a very important area that need to be, I think we need to concentrate more on it as medical education is. So with that, thank you very much for, we are fortunate to have all of you. And thank you very much for your time and effort and being with us and enriching the conference. Wish you all a very good morning for you and good
Thank you,
participants. Okay.
Thank you
It was
all.
a pleasure
Thank
to
you.
be here.
Bye.